Okay. Good afternoon. This is Dr. John Bennett. I'm broadcasting here from Miami. Today we have Carlos Llumiguano MD. He's a neurosurgeon from Real Madrid, and currently he's in Ecuador teaching neurosurgical residents of Ecuador. And today he's going to be speaking about stereotactic surgery in Parkinsonism. Also, well, we have a few people in the panel, one person joining now. So while Carlos is getting ready, Suri, could you please, whoop, Suri left. And we have Sheba. Can you hear me, Sheba? Well, I guess we might as well start, Carlos. Good afternoon, Carlos. Thanks for coming.
Okay, thank you very much for this possibility to do on a conference today. And like 2 weeks ago, we tell about Parkinsonism and their change after stereotactic surgery. In this moment, we will speak about the cognitive function change, the motor function change, and some manual text performance after deep brain stimulation of the subthalamic nucleus. For that, we can start to speak today that Parkinson's disease is described in 1817 by James Parkinson like shaking palsy. Actually, the prevalence is in the United States and Europe is about 150 and 250 per 100,000 per year. In China, it's about 15 per 100,000 people per year. But the incidence of this disease in USA is about 20.5 per 100,000 people per year, and China, this is about 1.5 and 1.9 per 100,000 per year. And when you speak about the historical overview about the development of stereotactic or functional neurosurgery, we can speak that we start in about 1950 when we speak about the Spiegel who doing a palidotomy in one patient with Huntington disease. In 1968, the development of functional neurosurgery was stopped because they are coming to treatment with levodopa, and the patient had a good relief of their symptoms. This kinds of treatment is stopped 5-7 years later when they are coming the complications or the secondary effect of the therapy. In 1993, Benavit, who is a French professor, started with the deep brain stimulation in patients with Parkinson's disease. After in Hungary in 1994, we started the functional neurosurgery treatment. In 2001, we introduced the techniques of neuromodulation in these kinds of pathologies. And we can see that for the surgical treatment, we have two options, like a stereotactic ablation or Llluniguano, like such as palidotomy, thalamotomy, or subthalamic nucleus ablation. This kind of technique do it just in one article who was published in 2006 for an Cuban neurosurgeons. And the further kind, we have a neurostimulation procedures that is non-invasive and is reversible techniques like a subthalamic, thalamic, or globus pallidus stimulation. After that, we will speak that we know about what is the effect of the thalamotomy or the pallidotomy or combined pallidothalamotomy in about on the motor function and the performance time. We know that the pallidotomy improves especially hypokinetic symptoms, and a thalamotomy will improve the hyperkinetic symptoms in this disease. The combined pallidothalamotomy can relieve both the hyperkinetic and the hypokinetic symptoms. We know that the ST and DBS can be improve the motor function, such as described by the Gaspari Draper-Ford in so many articles published in different journals. But at this time, we speak about 2006, 2007, don't have any kinds of data about how change after ST and DBS the patient's hand rate, if it is more faster, if it is accurate of these kinds of surgery. And what's about the effect of the ST and DBS on cognitive functions? In the international publishing data, we have very uniformity results. Some people, some authors speaks about improvement of the cognitive function. Other group will speak at the worsening of the cognitive function. And other group of the investigators speak or relate about that we didn't have any kind of change in cognitive function in patients with Parkinson's disease. And what's about the change of the metabolites after avoiding the metabolism in the brain? Some people, some investigators is doing a measurement of the certain metabolites of the brain in some regions of this central nervous system, like an striatum. Some investigators speak that the decrease of the metabolites, other groups speak and the unchange in the levels of the metabolites. Other group doing a measurement in the cortex, they are describing a decrease of the metabolic levels. Another group like a Chernow do it in these kinds of measurements in the thalamus. And they're describing another increase of the level of the metabolites. For that, we had a hypothesis that how to change a non-evaluated symptoms in Parkinson's disease after surgery. What about the slowing of the hand raising of the patients? What about the micrography? What about the softly and hand movement disorders and the coordination disorders? Or what about a cognitive function disorders? And the hypothesis 2 is the effects of the DBS are still unknown. It has an effect on the brain metabolism. If give some information for that and a proton MR spectroscopy in Parkinson's disease patients treated with subthalamic nucleus stimulation. The answer for this work was the evaluation of the effects of ablative pallidotomy, combined pallidothalamotomy, and ST/DBS neurostimulation procedures on the motor function in Parkinson's disease, evaluation of the effects of ST/DBS neurostimulation on the cognitive function in Parkinson's disease patients, evaluation of the effects of ablative pallidotomy, combined pallidothalamotomy, and ST/DBS on the time required for performing certain manual tasks in Parkinson's disease patients. Measurement of certain brain metabolite concentration by using proton magnetic resonance spectroscopy in Parkinson's disease patients treated with ST/DBS. There may be some correlation between the clinical improvements and the change of brain metabolic concentration occurred after neurostimulation procedures. For these kinds of work, we're doing a patient monitoring with, for the matter function monitoring, we use a phantom test, part B, and unified Parkinson's disease rating scale, part 3. And for monitoring the cognitive function, we use in a variety of neuropsychological tests like a mini mental state examination, auditory verbal learning test, Raven test, Bergen test, Montgomery-Åsberg depression rating scale, Hungarian Wechsler intelligence test, and a verbal fluency test. For the monitoring of brain metabolism by proton magnetic resonance spectroscopy, we know that the measurement of brain metabolic ratios produced during brain metabolism, this value is not an absolute value. We must know which metabolite can be measured in vivo. For example, we measure the N-acetyl aspartate. This marker has been localized in and is an putative marker of viable neurons and therefore possible indicator of neuron loss. Choline, this marker altered neuronal membrane synthesis and degradation can result in change in choline. Creatine is a key energetic metabolite and therefore a possible indicator of defective energy metabolism. For analyze the effect of pallidotomy and combined pallidothalamotomy on the motor function and performance time, we have 48 right-handed patients with Parkinson's disease. From them, 20 patients had a pallidotomy and 28 patients had combined pallidothalamotomy. In a pallidotomy, as a group A, is characterized by presenting mainly hypo or akinesia, rigidity, on-off fluctuation, and levodopa-induced dyskinesia. For pallidothalamotomy, group B, patients were showing not only the symptoms and signs of group A patients, but also had severe tremor. For analyze this, the motor function, we use an phantom test part B and UPDRS part 3. To analyze the effect of EST and DBS on the motor, cognitive function, and the performance time, we have 53 patients right-handed with Parkinson's disease. For analyze these functions, we use phantom test B part, UPDRS part 3, and different neuropsychological tests that were numbered before. For analyze the brain metabolic change, we use a proton MRI spectroscopy for the 53 right-handed patients with Parkinson's disease. In all patients underwent single voxel proton MR spectroscopy. The sample size were on the right and left globus pallidus and left frontabasal cortex. We measured the metabolic ratios from N-acetyl aspartate to choline, N-acetyl aspartate to creatine, and choline to creatinine. In these chapters, we will show the results and about the effect of pallidotomy and pallidotalamotomy on the motor function. In the left side, we will see the results of after pallidotomy, where we have a preoperative 51.2 points, and two days later after surgery, these results is decreased about to 29.5. At 6 months, this was 26. With this, we demonstrate the improvement of the motor function due to pallidotomy. And the same function analyzed after combined pallidotalamotomy, the improvement is markedly but not significant. Maybe because in this group of patients, because the disease is more progressive, maybe it's more deleterious, and maybe they have so many symptoms like hypokinetic and hyperkinetic symptoms. In this chapter, we will show the effect of pallidotomy just on the performance times. So in some manual tasks that are done by the patients, like the driving of big Archimedes spiral, driving of the small Archimedes spiral, the drawing of in a right line between 2 points, or to write on a standard sentence. If we see, we analyze in the left side in a preoperative measurements, and we analyze two days later or 6 months later, we see that the improvement of these kinds of task, and with this we demonstrate that the manual or finger movement is more faster and is more swiftly. The patient can move very well the hand, the patient can write very well, and maybe he had a good functional movement. If we see the same functions after combined pallidotalamotomy in patients of group B who present the hypo and hyperkinetic symptoms, and we see that the same functions demonstrate or showing some kinds of improvement, but there is not significant. In this picture, we will demonstrate how can change the standard sentence writing than a big and a small Archimedes spiral drawing and the drawing of the right line between 2 points. This, in the left side, we show the preoperative state, and in the right side, we show in the postoperative drawing for the patient. And we see that's a very important improvement on this kind of function. If we analyze the same functions in after ST and DBS, we will see that, for example, the standard sentence, big, small, and Archimedes spiral, and the drawing of the right line between 2 points, we will see how can improve this function, this task, referring to the preoperative state. And the same is happening in the motor function score referring to the preoperative state. We have a very good result. They present that a significant improvement, significant change when we evaluate this kind of functions. This is the sample in the left side when the patient doing this task in the preoperative state without the drug. This is in the central medium part is the drawing of task for the doing for a task in the preoperative stadium, but with the drug. So in its own state, these two samples is very different when we analyze in the postoperative state when the patient have an DBS in on state and the drug is in off state. For this, we can see or we can tell that after the stereotactic surgery, after the deep brain stimulation, the patient will improve significantly their motor function and their performance time. And after that, this kind of surgery, maybe it will decrease the necessity of the drugs. Maybe we can decrease the dosage of the drugs, but in some patients, we can keep out totally the necessity of the drugs. In this table, we can see how can change just the motor function according to the UPDRS evaluation. We have in a drug on, drug off in a preoperative stadium, and we analyze 3 months after the surgery, and we see how can decrease these points. With this, we can demonstrate that a significant improvement in the motor function. If we analyze the same for the certain manual task, do it for the patient in the right hand, here the patient, we have here the points of the values do it in the preoperative state and to refer to the postoperative state, and in this case, in the same like other functions, the patient demonstrated the significant improvements of the manual task, manual movements, like finger movements and open closing the hand. In this case, we will see, for example, when we analyze the measurement of certain metabolites of the brain, and we see we just find it and a significant change of certain brain metabolites in the left frontal-basal cortex when we are doing the N-acetylaspartate to choline. When we have a significant increase N-acetylaspartate to referring to creatine ratios, we have the same and a significant increase of the levels, but parallel to the significant decrease of the choline to creatine ratios. In this case, in this table, we see how can change the concentrations, the relative concentrations of brain metabolites. Right. If we can discuss about the new results of TINET, for the effect of pallidotomy and pallidotalamotomy on the motor function and the performance, and we can say that pallidotomy diminished the manual tasks performance time significantly. In a combined pallidotalamotomy, the decrease of the manual performance time was not significant, such as after pallidotomy. For the effect after SDN-DBS on the motor function and the performance time, we can say that SDN-DBS diminished significantly the performance time for manual tasks, improvement of motor scores. Accordingly, UPDS Part 3, special finger tapping, hand pronation, supination, hand opening, closing were significantly. The evidence of motor score improvement after SDN-DBS is in concordance with the findings of the other authors. Effects of the SDN-DBS on the acceleration of performance time are not exactly known, but seems to be ascribed to the suppression or relief of symptoms brought about by the operation. If we analyze the effect of the SDN-DBS on the cognitive function, we can say that after 3 months of the SDN-DBS procedure, during the cognitive function evaluation, just the auditive verbal learning test improvements were significant, and the results of the other applied neuropsychological tests were not significantly different. Taking bibliographic data into account, we suppose that the significant improvement of the auditive verbal learning test may be explained with the motor function improvements occurred after SDN-DBS and possible hair width, liner concentration, and visual spatial orientation capacity improvements. Internationally, the results are not uniform, probably due to the multiplicity of tests or protocols used for this function evaluation. In a proton MR spectroscopy, to our knowledge, this was the first study applying a parallel evaluation of proton MRI spectroscopy results and clinical improvement in Parkinson's disease patients following SDN-DBS. We have demonstrated that cortical N-acetyl aspartate choline and N-acetyl aspartate creatine ratios were significantly increased, paired with a significant decrease of choline creatine ratios in all patients treated with SDN-DBS. We observed that the decrease of N-acetyl aspartate choline ratios in the selected boxes in GP was insignificant. We demonstrate that besides the metabolic change, significant motor score improvements were observed 3 months following SDN-DBS procedure, and these improvements were also highly correlated with amelioration in motor function, primarily regarding bradykinesia. The only increase in the relative proportion of intact nerve cells linked markers as N-acetyl aspartate may suggest that the SDN-DBS may be protective, maybe neuroprotective. To do this, further studies are needed. Thank you very much.
Okay, Carlos, very good, excellent presentation as usual. Let me first introduce, there's a couple of panelists that you can't see, but they're here. You can see Surya Singh, an MD, he's a neurosurgeon from Bhopal. There's also a few doctors watching. Dr. Anuj, A-N-U-J, He's a maxillofacial surgeon from Bhopal, India, and a Dr. Shiba. He's a neurophysiotherapist. But due to audio problems, we can't hear them. And we'll start things off with Surya. Surya, do you have a question for Carlos? Can you hear me? Can you hear me, Surya? Hello, Surya, are you there? Sorry about that, Carlos. Okay, I want to ask a question, Carlos. It's just generally about stereotactic surgery. Now, this is confined to the big university centers, this type of surgery?
Yeah. Well, this study was started when I was in Hungary, in the Peach University, in the Department of Neurosurgery. We started with this kind of studies from about 1998, and after that, when we started with functional neurosurgery with implantation of SD and DBS.
Okay. Okay, so is your study, it must be the most comprehensive one out there for stereotactic surgery.
Yeah, this is our study.
It's probably one of the most comprehensive ones done.
We are following the study because we analyze into the other patients too. We will be finish these studies maybe in 1 or 2 years, because we need to have a long time following.
Okay, and these patients in Hungary and Spain, and they're still being followed.
Yeah, we just analyzing the results of the studies from patients from Hungary.
Okay. Okay, and generally speaking, how were the results look so far?
Sorry?
Generally speaking, how are the results in Hungary?
We have just analyzing the peoples from originally from Hungary who speak just Hungary.
Okay. Okay, Surya wanted to ask a question about stem cells being used. Are you familiar with stem cells being used in Parkinsonism?
Can you hear me?
Yeah, we can hear you now, Surya. Go ahead. Go ahead.
Hi, Carlos. Carlos, wonderful presentation. Very nice. I want to ask regarding stem cell therapy in Parkinsonism.
Yeah, this kind of treatment was proved in the 1998, and some treatment was do it before that, but they didn't have a good result. So nobody is following doing this. For that, we didn't have at this time scientifically based results. So maybe some groups will be is started with the treatment. Some groups start with the experimental treatment. But I think this we must stay for the results. So we want to wait.
Okay. Next one. Do you have any personal experience regarding prepontine nucleus lesion? It is a new target for the Parkinsonism.
Yes, I know about this new target for the Parkinsonism, but I am not doing that. So I am not starting with this target. Maybe I will be tried, but I must to analyze the really recommendations for these kinds of target for so many patients with Parkinsonism.
Okay, and what is your personal experience regarding the old age plus 60 plus patients of Parkinsonism?
Sorry?
Parkinsonism patients with more than 60 years of age.
We must to know to determine what when we are doing the project or some protocols from Parkinsonism or for the Parkinson patients treatment, we must to delimit the age of the patients, but it's about 65 years. But we must to decide individually. Maybe some patients with 70 years or 75 years can be a good candidate for this kind of treatment. But we need to analyze very well that if the patient really is indicated as a good candidate for this kind of surgery, because we not just analyze the chronologic age for the patient, but we must to analyze the biological age.
Okay. So every patient's different.
Yeah, or every patient's different.
Yeah. Okay. Suri, any more questions for Carlos?
No, fantastic presentation by Carlos. Very nice presentation by Carlos.
Yes, Carlos always does a good job. He knows PowerPoint and he knows Hangouts. Okay, so you'll be able to say that, are you doing any in Ecuador now? Are you doing any studies, continuing studies down there?
We will be start with the Parkinson treatment project with the functional neurosurgery here in Ecuador, maybe in 2 weeks or 1 month. We now are in the last stage.
Okay.
In administrative, bureaucratic situations.
Oh, okay. So that was the meeting you were in yesterday.
Yes. Yesterday was.
Okay. Well, I'm glad you came today, Carlos, and I'd like to thank you very much for taking the time to give us an excellent presentation, another one. And thank you very much. And Suri, thanks for coming. And for the other 2 gentlemen in the audience, thank you for coming, and we'll improve on the tech and we'll improve on everything. So very good. Thank you very much, Carlos.
Thank you very much.